And just backing up briefly, as it relates to your physical exam, is there anything unique about what you're looking for? Or is it kind of like, all of us, we see the rhinitis patient a lot. So how do you, I guess one thing that seems to vary between people we talk to is whether or not you decongest the nose when you're looking at it.
Oh yeah, yeah. That's a great question. All right, so I used to do lidocaine and oxymetazoline, Aerin on everyone for my scope examination, and then something called a pandemic happened, right? COVID happened, and where there were all these concerns about like aerosolization. Yeah, it was a small thing. I don't know. Something you might have missed it.
Little blip.
Yeah. And during that procedure, we kind of learned how to do these nasal endoscopies on patients without using decongestants or topical lidocaine. And actually, I found that actually has been really helpful in my diagnosis, right? Because in the past, anytime you decongest someone, everyone knows it looks wide open, right? But now that I'm scoping people without that decongestion, now I can see exactly what it looks like, how swollen those tuberculosis are, how edematous mucosa is. So I think it's actually really improved my ability or how much what I'm catching on that nasal endoscopy. So everyone has these posterior nasal nerves. So as far as anatomical, as far as like who's a candidate, who's not a candidate, I think it's the physical examination is a little bit less important. But there are certain things I kind of look for that kind of help determine, that kind of weigh in on that decision making, right? If I look inside the nose and I just see tons of mucus, tons of edema and swelling, a lot of times that to me means that, okay, this might be someone that may benefit from the procedure, right? If I look at it and the nose just looks super clean, then we have to start looking for possible other etiologies of that nasal congestion, nasal drainage, right? Whether it's like reflux or something else that might be contributing. The other thing that the physical examination helped me with is figuring out where to do this procedure. Right? I do this procedure both in the operating room and in the clinic. Right? So if someone has a pretty easy anatomy, then I usually offer the in-clinic version, because I think in general, patients kind of prefer to avoid general anesthesia whenever possible. But if they have really tough anatomy, things like a really widened middle turbinate or really severe septal deviation, that I do put a strong consideration into doing this in the operating room. A lot of it is just kind of determining how well the patient will tolerate it, right? I'm sure you've all had this, where you put a scope in someone's nose, you haven't touched anything, or you're even just getting close to the nostril and the patient's already jumping out of the seat, right? Those patients are not a good patient for an in-office procedure, right? But if they are pretty stoic during the procedure, if they tolerate the endoscopy pretty well, then in my mind, that's a great patient where I can offer an in-office version.
And just backing up still, Dennis, in terms of your allergy patients, do you want them to have tried like immunotherapy for a while? Do you counsel those patients a little bit differently than your non-allergic rhinitis patients?
Yeah, that's a great question. So we had the privilege of working with a lot of different allergists in the area, and they're all really, really great. And so it's someone that presents to me with like allergic rhinitis, I always tell them is you're the patient where I'm partnering with the allergist, right? The allergist, they take care of the inflammation, the allergy components of it. What I could take care of is the anatomical portion of it, right? And so when it comes to the discussion of immunotherapy, I really leave that up to the allergists, right? To have that discussion to see whether it's going to be effective for this patient and how long to try it for. As you probably know, the allergy immunotherapy takes a long time before it starts working, sometimes years, right? And so if the patient's really struggling, and even if they are already on allergy immunotherapy or maybe just started it, I may still offer this procedure just to see if we could expedite some kind of response, right? Because they're struggling now, right?
They're still going to have a couple of years.
Yeah, exactly, before they start getting the benefit, So I want to do something that might be able to offer them some benefit or some improvement in the quality of life.
Yeah, it doesn't have to be either or. It can be and.
It can be both.
Yeah.